Thanks everyone for this Living Well Inflammatory Arthritis webinar. We're so excited that you're here. We're so excited that you're here to learn about arthritis, how to manage it, learn about this disease from an outstanding expert. And I think it's just about time for us to begin the program. My name is Nick Turkis. I am the Senior Director of Patient Education for the Arthritis Foundation, and I am thrilled that you are here with us to learn about arthritis, learn how to track your symptoms, and most importantly, communicate how you're feeling and those symptoms with a trusted healthcare provider. I want to go over a couple of quick ground rules for our presentation. First, all of your lines have been muted. But please know that we do have a Q&A function for you to ask questions. You can type them in, and those questions will be reviewed by our behind-the-scenes team. We'll be answering some of them in chat, and some of them we will answer live at the end of our presentation. We also have a post-event survey. Those surveys are so important to let us know what you're interested in, and that helps us put together programming for the upcoming year. We always get asked if these webinars are recorded, and yes, you can find this webinar and many other outstanding webinars in two places. You could go to youtube.com/arthritis foundation, or you can go to arthritis.org/webinars, and there you will be able to find it. And everyone on this call will be emailed a copy of the presentation. So fear not, you will definitely have that presentation sent to you. But let's go ahead and get started by introducing our guest expert tonight, Vicki Ruffing. Vicki Ruffing has been a member of Johns Hopkins Arthritis Center since 2000, currently serving as the Director of Nursing and Patient Education. She has been involved in numerous clinical trials for biological and non-biological therapies in arthritis. Her position at the Johns Hopkins Arthritis Center has allowed her to pursue her passion for patient education. She has developed numerous educational initiatives, including a video series for patients with rheumatic diseases. You can find it at www.rheum.tv. Likewise, she has been the course director of the annual Division of Rheumatology Continuing Medical Education course since 2010. Ms. Ruffing was the founding member of the Rheumatology Nurses Society, incorporated in 2007, as a resource for the growing number of registered nurses entering the field of rheumatology. Under her leadership as president from May 2008 until 2010, the society grew to 400 members. She's been successful in promoting rheumatology nursing as a new field of nursing. She has worked toward the development of a certification process for nurses in this discipline, developing curriculum and training standards. She has developed and directed 3 conferences for the Rheumatology Nurses Society, and she has been a stalwart volunteer for the Arthritis Foundation, providing education for our webinars, podcasts, and in-person events. And so we are just so excited to have you here, Vicki, and I am going to pass it off to you. Thanks so much.
Tonight, we're going to talk about understanding different types of arthritis and spend most of our time talking about inflammatory arthritis. I'm going to explain the differences between an inflammatory arthritis and osteoarthritis. We'll talk about medical management and what you and your doctor can do for inflammatory arthritis. We'll talk about some self-management techniques. We will talk about some alternative treatment plans, and we will talk about some resources for you to be able to find out more information. Okay, so inflammatory arthritis is an autoimmune disease. And I just want to spend a second talking about what does that mean, an autoimmune disease? Autoimmune diseases are something has gone haywire with the immune system, and our immune system is meant to fight off germs and, let's say, foreign invaders to us. But when people develop inflammatory arthritis, what's happened is the immune system is attacking itself. It thinks that what it sees is foreign and goes after it. And because it's not foreign, it doesn't disappear. So the immune system has to keeps working in this vicious cycle to keep trying to get rid of what it thinks is foreign. So this is a systemic disease, which means it's through your whole system. And what makes it different than osteoarthritis is a wear and tear kind of arthritis. And while there still may be some inflammation involved in it, it's localized to the joint, not through the body. Inflammatory arthritis, we know that there are genetics involved, but something triggers it. And it's not caused by what you ate or what you don't have as far as vitamins or minerals go. Some people can absolutely define when it started. Perhaps it was after a trauma. Perhaps it was after a pregnancy. Many people can say, this is when I got it, and like pinpoint the day that all of a sudden it was turned on. Next slide. So some symptoms of inflammatory arthritis are morning stiffness. So that feeling when you get out of bed and you've got to sort of work your joints a little bit, or you're walking a little slow, or you wait until you get your hot shower to be able to move. Joint pain, tenderness, and swelling that lasts for 6 weeks or longer. The joint pain and tenderness and swelling most oftenly are going to be found in the small joints with inflammatory arthritis. That means joints of the fingers, joints of the wrist, the ankles, the feet. That's true in rheumatoid arthritis, and we'll talk about that a little bit more. In psoriatic arthritis, it can be the larger joints like the knees and hips. And in ankylosing spondylitis, it's the spine. Another symptom is fatigue. Regardless of how much sleep a person is getting, they still may feel really run down. Low-grade fever, some people get. Symptoms can come and go. And remember that these are systemic diseases and they can affect other parts, not just your joints. Next slide. So joint pain that is not inflammatory or autoimmune is probably OA. So OA is most common in the bigger joints. As we get older, we think of our hips and knees mostly, but shoulders are common, elbows, fingers. Some people you will see that have their knuckles sort of are distorted, or their knuckles are getting larger, and they're hard to the touch. You can almost feel that there's like either an overgrowth of bone or the things are slipping in there. So that's sort of what OA is. Now, that doesn't mean if you have an autoimmune disease, you won't get OA. It's not exclusive. So you can have both at the same time. A lot of times we see these begin later in life. The osteoarthritis begins later in life than the inflammatory arthritis does. So rheumatoid arthritis is the most common type of inflammatory arthritis, and it affects more women than men, about 70% women versus 30% men. It usually begins between ages 30 and 60. More towards that younger age for women, and more towards the older age for men. Usually it affects more than one joint, and it can be symmetrical, meaning if your right index finger is involved, your left index finger may be very well involved. So a rheumatologist will look at all these different pieces and come up with your diagnosis. Next slide. Psoriatic arthritis is excuse me, it is not affects just the joints, but also the skin. So many people with psoriatic arthritis will have psoriasis. If they have psoriasis in their scalp, they're more likely to have psoriatic arthritis. People can go years and years with psoriasis and not develop any type of arthritis, but about 1 in 3 people do develop psoriatic arthritis. Psoriatic arthritis falls under the big header of spondyloarthropathy, which can affect the spine and the pelvis. Some of the things that are different about psoriatic arthritis is there's a symptom called dactylitis or sausage digit, where the entire finger or toe will swell to the same size, like a piece of sausage. That's one thing that triggers to think of psoriatic arthritis. The other thing that's common is the nails are often involved. They get little pits in them, and they can start to come away from the skin underneath. Enthesitis pain and inflammation. Enthesitis is when there's pain where your tendons or ligaments that connect to your bones get really inflamed. If you think about your Achilles tendon, most people know where their Achilles tendon is. That is not an uncommon place for people to have pain, and it really hurts along the heel, where that tendon is where the tendon is attached to the bone there. Now, axial spondyloarthritis, which could be some things like ankylosing spondylitis, or it can be more generalized, like just the axial spine. That is primarily the spine and the pelvis and the buttocks. Now, you can see joint damage once it's happened on an X-ray, but more commonly, you need an MRI to diagnose this. They really look at the sacroiliac joints, because that's where it tends to start. And if inflammation is seen on MRI there, then you'll get a diagnosis of ankylosing spondylitis or spondyloarthropathy. Now, you can get it without seeing any damage. You can also get the diagnosis, but it will often progress that eventually you would see the inflammation on MRI. Now, in ankylosing spondylitis, which is a little bit different than just spondyloarthritis, the ankylosing part is what happens is the spine will fuse itself. It actually will fuse and not be able to bend. And it can happen in other joints besides the spine with people with ankylosing spondylitis. Next slide. So how does inflammatory arthritis affect you other than the joints? So we talked about the joints, but what will happen with untreated inflammatory arthritis, regardless of the type you have, is that permanent damage can happen. What we see happen is when that inflammation stays in that joint and we're not getting it cleared and we're not treating it well enough, the bone can be eroded away. It actually, it can just look like chips are taken out of bone. And you can't get that back. There's no way to get that back. It also will eat away cartilage and cause so much swelling that you're putting pressure on your tendons. And once those that type of damage happens, you have it permanently. It's a permanent thing. So it's so important to be diagnosed and treated aggressively and treated early for this. The heart. There is an increased risk of heart disease with people with inflammatory arthritis. They seem to, so if they seem their heart and vascular system seems to age about 10 years faster than the normal population. There are metabolic conditions that can also happen. Once you have one type of an autoimmune disease, you are more susceptible to another, like diabetes. We also see patients with obesity and liver issues. Another common side effect, if you will, or comorbid condition is anxiety and depression. It's distressing to get a diagnosis of something that's going to be chronic that you're going to have the rest of your life. So it's natural for patients to, be unsure about the future and how things will go. Inflammatory arthritis can affect the skin with nodules. In psoriasis, with the psoriatic arthritis. So skin issues are not uncommon. Next slide. RA can affect the blood vessels. It can lead to damage in the nerves and skin. Anemia is not uncommon. Where you and that may be also one of your fatigue reasons for your fatigue. The lungs can be affected. They can be affected by the arthritis, the systemic arthritis, but it can also be affected by some of your medications. So your rheumatologist is always going to be on the lookout for any type of lung involvement. Osteoporosis is a decrease in bone strength and can lead to fractures. This is another common, I wouldn't say common, it's another side effect that you may find. Inflammation of the eyes, especially in the spondyloarthropathies, is common. Iritis, uveitis, scleritis, where the eyes become really inflamed and need to have urgent treatment. Also, gastrointestinal disorders. These can run hand in hand, especially with the spondyloarthropathies, patients that have Crohn's disease or ulcerative colitis, irritable bowel syndrome, inflammatory bowel. Those things can go along with any of the inflammatory arthritis. Next slide. Now, osteoarthritis, what we had talked about, the wear and tear type of arthritis, that affects the joints, but it can affect the heart, and it can lead to osteoporosis and some of these other disorders, but that is generally the effect of not moving around. People with osteoarthritis need to keep moving. They need to make sure that they're watching their weight, because it's very easy to, if you're in pain, think, well, I don't want to move. I don't want to move around. And so we need to make sure that that's not happening, that people stay active. Next. Okay. Now, if you have inflammatory arthritis, some of the things that you're going to look for maybe you've only had joint involvement, but if you should develop persistent cough, chest pain, stomach pain, cramps, nausea, these could all mean that you have a comorbid or another condition developing. So any numbness, burning, tingling in your legs, hands, arms, if you have increased thirst or urination, these can all signal perhaps diabetes, perhaps and one of the inflammatory bowel diseases. So you want to make sure that you're paying attention and just keep in the back of your mind, this could be linked to my inflammatory arthritis. So all of the things that we're discussing tonight can be seen, it can be, you can get a deeper dive into some of this stuff through the webinars that are on arthritis.org. So if you just go to arthritis.org webinars, you can find the webinar from last month, which was Inflammatory Arthritis Challenges and Solutions. There's also plenty of webinars on exercise, mobility, diet, managing some of these other comorbid conditions that we've been talking about. So let's get into the medical management of inflammatory arthritis. There is no cure for arthritis. And one of the hallmarks of these diseases are what's called flares. So the goal is to keep you at the highest functioning level that you are today. We want to, or that we can get you to. But sometimes things happen in our lives. We move. Somebody a loved one may pass away. There's some other big stressors. And sometimes these can trigger what are called flares. And that means that the symptoms come back. And often your rheumatologist will give you a rescue medication to just deal with it, clear it up really quickly, and then you stay on your background medication. Next slide. There are medications, that to help control and to reduce the flares. One thing I just wanted to say here, if you are already somebody that has inflammatory arthritis and you're on a medication and it seems to be working, but all of a sudden you have a flare, that's to be expected now and again. But if it starts to become a routine, like every other month you have a flare, make sure you're bringing that to the attention of your physician, because it may mean that the maintenance medication you're on needs to be changed. So, working with your doctor, you're going to be able to live well and have a great lifestyle. Next slide. So some of the medications for inflammatory arthritis, we'll go over, we're going to go over those now. This is sort of a longish slide, but NSAIDs are over-the-counter prescription, over-the-counter and can be by prescription. NSAIDs will also help with osteoarthritis, not just inflammatory arthritis. NSAIDs, however, do not change the course of your disease. They are only for pain. They're only an analgesic. So things like ibuprofen, acetaminophen or Tylenol, naproxen, those are over-the-counter medications that you can get and that you take, but they don't change the disease. So while it may make you feel a little bit better, it's not doing anything systemically to fix things. Corticosteroids, those are also anti-inflammatory medications. Those have some pretty serious side effects. So A lot of times they're used just to get you out of a flare, and then you go back onto your maintenance medications. They really do control inflammation, but they cannot be a long-term solution. They can cause things like glaucoma, diabetes, heart disease, osteoporosis. I could go on and on and on. So they're not a long-term solution, but taking them quickly, like for a short amount of time, is fine. Inflammatory medications for inflammatory arthritis, there's something called conventional DMARDs. A DMARD is a drug that will actually change the course of the disease. It works on the disease rather than just your joint. So it stands for disease modifying anti-rheumatic drug. So those DMARDs are things like methotrexate, sulfasalazine, hydroxychloroquine. Those are conventional DMARDs. There are also targeted DMARDs. The biologics and the JAK inhibitors are both targeted. They target one specific part of the immune system. So, for example, the JAK inhibitors, they target what's called JAK, which is an enzyme that is in that immune process that we talked about in the beginning, that sort of cycle of inflammation that comes on. The biologic DMARDs, they also target, and there's several kinds, so they may target what's called a cytokine called TNF, or IL-1, or IL-6. So we have come a long way in therapies where we can actually pinpoint one part of the immune system that is involved in inflammation and see if we can break that cycle. Now, you may have heard of something called biosimilars. There's no such thing as a generic biologic drug because the biologic drugs are made from a cell line. It could be a mouse cell, or it could be a human cell line. And the generic type of biologic that you get is called a biosimilar. So they have to grow their own cell lines. They've been tested just the way a regular, an original biologic is tested. So they are safe. And there doesn't seem to be any difference in how effective they are from the original product. Next slide. So I talked about methotrexate. I just call this out because methotrexate is probably the most common drug that's prescribed for people with inflammatory arthritis, but not ankylosing spondylitis. It does not help that. I think the latest statistics are about 70% of people with inflammatory arthritis have been on or are on methotrexate. So it's a safe drug, it's effective, and it's relatively inexpensive. But it does come with some side effects. Hair loss and is possible, not guaranteed. Nausea for some people, mouth ulcers, that kind of thing can happen with methotrexate. If you're on methotrexate, you have got to be on a contraceptive if you're still of childbearing age. We give people folate or folic acid to help combat the side effects. And methotrexate is metabolized in the liver. So you do want to avoid alcohol if you are on methotrexate, because that is also metabolized in the liver. Some of the side effects of biologics and JAK inhibitors, they can increase your infection risk. If you get an infection while you're on those, you want to contact your rheumatologist to find out if they want you to stop it while you would be on an antibiotic. And then you can start back up again. There are injectable biologics and there are infusible biologics. So an injectable biologic, it's often an auto-injector and you would give yourself a shot, or there's infusible, and we'll talk about that in a sec, where you would go into an infusion center and get your drug by IV. So there could be, if you're on an injectable, if you're giving yourself a shot, you could get an injection site reaction where you injected the drug. You might get a little welt there. It might get itchy. It might get red. It may even bruise. But if it becomes a problem, you're going to contact your rheumatologist and let them know that what the issue is. There are a lot of tips on helping with methotrexate side effects. Maybe split the dose. It's not the greatest idea, but if you have to, you have to. You could take one in the morning and one at night, or take half in the morning, half at night. We have put people on anti-nausea medication. We have put people on injectable methotrexate, where they give themselves a shot rather than take it by pill. And if you do have the mouth ulcers, you can, there's rinses that you can buy over the counter to gargle with and swish with. But if the side effects are too unbearable, you just need to let your rheumatologist know, because you don't want to go with no treatment. So they may just be able to switch you to something else. Next slide. We had talked about the biosimilars and reference biologics, or the originator. So I had said they're safe and effective, that they do go through the FDA approval process, just like any drug does. They're the same strength and same dosage, and they're given the same way. I think some people are under the misconception that the biosimilars are not as good as the original product. But that isn't true. They have to have reached the conclusion that there is no meaningful difference between the original and the biosimilar. So I hope that people are not getting it in their head that because it's not original, that it's not as good. So the good thing about the biosimilars is it can help with insurance costs. I'm sure it helps with insurance costs. And maybe that's just a little bit cynical for me to say, because most of your insurance companies are going to insist that you switch to a biologic to a biosimilar if there is one available for the particular drug that you're on. Next slide. Oh. So injections versus infusions, and this is what I was saying. Some drugs only come in an injection, and some drugs can only come in infusion. So it's important that you think about your lifestyle and what maybe is better for you. The biologics have to be injected right now. We don't have an oral formulation of them now. So you do have to inject yourself. What you see here is a picture of a drug called Humira, and it comes in a pen, and you would be taught how to use it, push a button, and it would shoot into the area that you need it. You inject in your belly or in your thigh or your upper arm. The idea is that you inject this somewhere where there's fat stores, because it gets injected under the skin into the layer of fat and then is slowly absorbed through your system. And if we had talked about injection site reactions, if you got if you had redness or swelling or welt, then you just want to keep an eye on that. If it's troublesome, let your rheumatologist know. Infusions are another alternative, and those would work for people who really can't administer a shot, or they are on a medication that there is no shot available for. So, you would go to an infusion clinic, and they have most of them have nice, comfortable, like recliner type chairs, and the nurse will hook an IV up, start an IV, and depending on the medication that you're on, it may be only a 30-minute medication, or it could be a 5-hour medication. I will say that the 5-hour medications are only once every 6 months, 2 weeks apart, but they're some are a month apart, the 30-minute ones. Some of them are 2 months apart. So it just depends on which drug. Not all of them are the same. While you're in the infusion chair, if you start to feel funny, you just need to notify the nurse that you feel funny, and it could be anything from your lips tingle to your ears burn. I mean, it really, nothing is too small to notify the nurse to say, is this right? I feel funny. If you develop something after you leave there, after you leave the infusion center, you can always call your rheumatologist and say, I got an infusion yesterday. Today I feel XYZ, and then see what the rheumatologist would say to that. Next slide. So we talked about the infusion center. Some of them have private rooms. Some of them you're in a big room, and you might have curtains in between the different chairs. Some physicians have a place right in their office where they do infusions. In the hospital, it probably is going to be a large common area with the curtains. And then some therapies can be administered at home. It depends on your insurance. I will say that the American College of Rheumatology does not prefer that these drugs be given at home, because you could develop a reaction to an infusion at any time. So, I think we prefer not to, but sometimes you've been on it a long time and it's relatively safe, then you may be able to do it as a home therapy. I'm just talking about inflammatory arthritis therapies, not other rheumatic diseases. Some of those can be done at home. So if you are going to have infusions done, your physician will probably will have to write orders for that drug to wherever you have chosen, or wherever your insurance company has chosen. And then, you can always take a tour of these places ahead of time and say, is this really where I want to spend, the next year or so, every once a month? And it may be convenient. And if it, some places, since COVID, some places are funny with blankets and that kind of thing. So some people bring their own blankets. It just depends. But you can find that out. You can call and find those kinds of things out. You definitely want to look at what's going to be easy to access, what's closer to home, because you don't want to miss these appointments. You want to make sure that it's registered nurses that are taking care of you. And other staff, support staff are there. And most of the infusion centers are going to know if there's a copay card that the drug comes with to help with the cost of your medication. In the state of Maryland, I can't speak for you, but we do have transportation assistance through the Department of Motor Vehicles, where they will transport you to infusions and take you back home. And you really want to make sure that you have your staff there is going to help you coordinate and make sure that you understand all the directions before you're released to go home. Next slide. Now, drugs you should worry about. Over-the-counter drugs. Please make sure that you are informing your rheumatologist if you are taking an over-the-counter drug. It's important because we at the rheumatology office do need to know what maybe if we didn't know that you were taking aspirin, 8 aspirin a day or something outrageous, we may think that your upset stomach is because of something else. So please just be honest about your medications, because too much of any of those NSAIDs can cause GI bleeding and ulcers. So we don't want to see you get in trouble that way. Tylenol can hurt the liver if you take it too much. So you want to make sure that you're using these medications correctly and thoughtfully. So you want to get more information about over-the-counter safety. There is a website here, getreliefresponsibly.com. And again, you'll be able to find all of these on the Arthritis Foundation website. So other medications that may be helpful are topical medications, which means over the skin, like patches, Voltaren gel, those kinds of things may help. Your rheumatologist may also do an injection, or sometimes an orthopedist may do the injection, where they will inject some steroids directly into the joint that is troubling you. They may also withdraw some fluid if you've built up a lot of fluid in that joint. So those can be helpful and are just sort of alongside of what you're going to be on for maintenance medication. Excuse me. Next slide. So if your joint has really reached its end, and you would see this in osteoarthritis or sometimes in inflammatory arthritis, you may consider a joint replacement. Now, that would certainly help your knee or your hip or wherever your issue is. So, but how do you decide when it's time to do it? And I think the biggest thing is that the pain is so much that you cannot do what you want to do anymore. You cannot get on the floor and play with your granddaughter. You cannot garden. You cannot get back and forth to work. So if it's interfering with your daily activity or an activity that you enjoy, then it's time to seriously consider joint surgery. Is the pain there when you're lying down, or is it only there when you're using the joint? Is there no way to get out of the pain? Is the pain preventing you from sleeping? So those kinds of things are what you would want to consider before you would get a joint replacement. Now, a joint replacement is invasive. It has to be done in a hospital. There's a lot involved there. So that's important. Now, arthroscopy is where they go into the joint with a camera. And usually you're seeing that done for soft tissue issues, torn meniscus, or there's a tendon that needs to be repaired. Next slide. So we've talked about a lot of different things, and I keep harping on making sure you're talking to your healthcare provider, your rheumatologist, but you want to be a partner in your care instead of having somebody just dictate to you what you need, and what drug you should be on, and how. But it's important that you figure out how it's going to affect you. So, as I had said before, your goal is going to be functioning at the highest level possible. And by doing that, we would reduce pain. We want to reduce what type of stress we're putting on the joints, minimize fatigue. And when it comes to medications, I stressed this earlier, please make sure that you are taking your medications. And if you're not, let your doctor know, because if you're not taking them, the complications that you can end up with by not treating your inflammatory arthritis can be pretty bad. Remember that damage is irreversible. So there are the days of there was only one thing that you could take are gone. So there's a lot of options out there, and working as a partner to explore what's going to work best for you is really where you want to go. Next slide. So how do you manage your care? There are a lot of people that are involved in the team. So hopefully there's a nurse or a social worker or a case manager. Sometimes your insurance company has navigators that can help you with how complex sometimes the care is for inflammatory arthritis. It's really a good idea to sign up for the patient portals that your doctor's offices offer. It's a great way to be able to communicate, because you don't have to wait till tomorrow morning. Oh, I better remember to call tomorrow morning. No, you can send off a message to your healthcare provider at any time. Don't expect them to answer at any time, but you know, you can do it in the here and now. And you do want to make sure that we have all your contact information. So whatever is happening at the rheumatologist needs to be sent back to your primary care doc. So some people like to track their arthritis, and they just keep a little notebook. And they say, today my index finger was bothering me. And then the next day it says my index finger was bothering me. So that when you go back for your appointments, you've got some record to see how things have been going over the interim since you were last there. Next slide. Okay, well, we're going to try to, I guess I better move a little bit faster. So these are the kinds of things you want to track. You want to track your pain. You want to track your sleep, your moods. You don't have to, you should track your water intake. You don't have to write that down though. Your food choices, symptoms, activity, the amount of activity you did, and then the ability to perform not just your daily work type activities, but also your leisure type activities. You want to say, can I still, go for a nice walk in the park at the end of the day? Or so you keep track of all of those kinds of things, so that you're living well. Next slide. So these are so fatigue, joint pain, rash, you're going to track those. And, these things can crop up at any time. Again, you want to be a partner with your rheumatologist and their office and making sure that you are doing everything you can for yourself, as well as partnering in making sure that your rheumatologist is also keeping an eye on your entire well-being. Next slide. So here's a myth about inflammatory arthritis, that you can't exercise. You can exercise, and it's very good for you. Now, what I would say is do not over stress your joints. So deciding the first nice day in April to go outside and till an entire garden, that is not a good idea, because that is too much stress. So you want to pace yourself, but you do want to keep moving. Walking is great, even if you can do it for just 5 minutes a day to 10 minutes a day. Keeping yourself moving is really good for the joints. The Arthritis Foundation has a Walk with Ease program, and you can find out more about it at arthritis.org, WWE, Walk with Ease. And think about some other types of exercise besides walk. I mean, that program starts you off slow and helps you really build up your confidence. Other exercises that are good are water aerobics, water exercises, yoga, and there are chair yoga programs out there, Tai Chi, and cycling on a stationary bike. Diet can cure inflammatory arthritis. No, it can't. It's important to have a healthy, balanced diet, but there is no such thing as anti-inflammatory foods. It'd be great if there were, but it's just a healthy diet. Again, you can find out more about this at the Arthritis Foundation. So you want to build healthy habits. And how can you do that? You just do one small step at a time. So the example here is adding blueberries to my cereal. Another example may be parking farther away from your grocery store so that you walk a little bit more. Taking a flight of stairs instead of at the elevator the whole way. Alternative therapies can replace medications. That is not true. So you need, alternative therapies are great. PT, OT, acupuncture, massage, dry needling, ultrasound, all of these things can complement what is happening right now with your maintenance medications, and the plan that you have set up with your doctor. They're an adjunct. They are not in place of. Remember, there's not a cure. So, you need to kind of go at it from all sides. Supplements are not substitutes for medications either. Remember, only the DMARD drugs that we talked about are going to modify the disease itself. These supplements, fish oil, curcumin, CBD, vitamin D, those are all probably fine, but please discuss it with your doctor before you incorporate anything in. They may have more information, and they may have other supplements that they think work well. So just make sure that that's in the conversation. So if you have any questions, there is a helpline at the Arthritis Foundation. You can call it, or you can email, and they will help you better understand your disease, interpret your insurance, help you connect with other people, and you may decide you want to get involved and volunteer at the Arthritis Foundation.
Fantastic information. So helpful. And we have lots and lots of questions. And I'm going to start off with a doozy. So we have a friend here who has been to 3 rheumatologists and has been given 3 different diagnoses. Who does she believe, and does she have to go to a 4th rheumatologist to get an answer?
Well, I mean, I think I will say this. Rheumatic diseases, all of them, are sometimes tricky. One disease might look like another disease. And in some diseases, like for example, psoriatic arthritis, there is no blood test that's going to say, oh, you have psoriatic arthritis. And that's true in many of the diseases. So sometimes what they're doing is ruling out everything else that they see to come up with what they think you might have. What I would suggest to that person, though, is to perhaps be seen at a large, well-known academic institution. So Mayo Clinic, Johns Hopkins, Cleveland Clinic, where you have a lot of rheumatologists there and they're doing cutting edge research. I would ask to see if that would be a little bit better than just if you go to 3 community rheumatologists. I think that might answer more questions for you.
Great advice. Got another question here. This is from someone who was diagnosed with rheumatoid arthritis about 25 years ago. She's currently taking Xeljanz, but since the last summer, she's developed pain in her hips, low back, and buttocks. Should the Xeljanz be helping with this, or would another drug be added to lessen the pain of the hips? This patient also suspects that they may have spondyloarthritis.
So I think that needs to be discussed with the rheumatologist. Certainly, rheumatoid arthritis, we don't often see things in the spine and the hips, and I can't diagnose somebody over the phone. I would just say I think it definitely warrants a discussion to find out what could be the other pains that she's having.
Yeah. Pain in hips and lower back could be a sign
Be
of hip osteoarthritis as a result of that rheumatoid
it could be
arthritis.
osteoarthritis, it could be spondyloarthritis, but certainly it should be investigated.
Definitely investigated. Great point. Great point. We've got a friend here who is on methotrexate and takes folic acid about 2 milligrams daily on days that they don't take the methotrexate. But she still has a lot of hair loss and mouth sores. Can I ask if I can increase to 3 milligrams of folic acid to offset these side effects?
Usually, going above 2 is usually doesn't seem to help much, but there is another drug out there that could be prescribed. So I would definitely talk to the rheumatologist to find out if you could try something else. There's a drug called leucovorin that sometimes we put people on that have side effects, and that may be helpful. But if it really becomes a problem, then methotrexate may not be the drug for you.
Excellent. Thanks for sharing that little tip. That's a great one. Next question is, our friend says that they've been using methotrexate for years, but sometimes they get methotrexate sodium from the pharmacist. Is there a difference between methotrexate and methotrexate sodium?
Was that the, No, I mean, methotrexate is methotrexate. Sometimes it might have a different name depending on the manufacturer, but no, there's no difference between methotrexate and methotrexate sodium.
Thanks for the clarification. Next question is, meloxicam was great, but caused extreme stomach pain. That's very common with many NSAIDs. So the doctor told me to take Celebrex. I avoid taking anything and just live with the pain. But it would be nice to have not have any pain because it really does affect their lifestyle. So the question is about, would Celebrex be a good option to deal with the stomach pain from NSAIDs? And, is there another type of doctor that would be better to answer that question?
No. I would think that if the rheumatologist offered an alternative to the meloxicam, and offered Celebrex, that may be, it might be worth trying to see if you still have stomach pains.
Mm.
But the stomach pains are concerning because you may end up that you don't want to end up with an ulcer.
Sure.
Even though these are prescription, it doesn't mean that they're safer than over the counter. So any of the NSAIDs, which is what those are, can cause issues. So you definitely should see if you should be taking another medication with it, or maybe looking for a different way to manage your pain.
All right. We have a friend here that once had a lymphatic drainage massage and then had a flare shortly after. Was that a coincidence, or do people with inflammatory arthritis have to be careful with massages?
I have not heard people be needed to be careful with massages. In my clinicals, I can only go by my experience, but a lot of people get massages and don't have flares. Now, the fact that it was a lymphatic massage, it could have made it. I really don't know the answer to that, and I don't want to try to make anything up. But people go in for facials and rub downs and all kinds of things, and they don't end up flaring because of it.
Good point. It's always a good idea to tell your, masseuse that you have arthritis, and if you have
Yeah.
any sensitive areas, absolutely. But that's a great point. Next, we've got a question about someone who wants to know how they can be active even during flares. This person can be in a flare that can put them on bed rest for sometimes weeks, and that recovery can be really rough with the muscle loss of not being physically active.
Right. Gosh, I don't know why they're putting you on. I mean, I understand the need that you feel to have bed rest during a flare. And certainly we would like our patients to get more rest during flares so that they can, sort of catch up. But I think what would be a good idea is to ask your rheumatologist to perhaps refer you to PT. Physical therapist may be better equipped to discuss with you what kind of movement you can be doing during a flare. It may be something like chair yoga, or something where you're really not stressing specific joints. But I mean, I'm not a physical therapist, and I think that they could probably answer that much better than I could.
Definitely, definitely. Have another question here. We have a friend who fell about 2 weeks ago, and even had a blackout from it. They had severe joint pain, worse in the shoulders and in the morning, and is wondering, could this be the beginning of rheumatoid arthritis, or is it unrelated to arthritis and will go away? It's been about 3.5 months since the fall.
I I really don't know. I
Yeah.
mean, I think you need to talk to the rheumatologist about that. They may need to look and see did something else happen. It may require some workup, like MRIs, or who knows. Yeah.
Yep. Definitely, definitely.
I don't
Any
want to,
kind of any kind of traumatic fall definitely need
yeah, I
a
mean,
healthcare
especially if there
provider to
was a
check it out.
blackout
Yep,
involved, definitely you need to talk to your healthcare provider about that.
absolutely. Can you tell us a little bit more about that large clinical trial at Mayo?
I don't know anything about a large clinical trial at Mayo. What I had said about Mayo was that if somebody feels like they can't get their diagnosis, or they're unsure of what a local rheumatologist has said, that they go to a large academic center
Got it.
to get for a second opinion or a fourth opinion. Someplace like Mayo or Cleveland Clinic, or every state's got somebody. You know, and actually, I know the Arthritis Foundation has a website where you can find a local
That's right.
rheumatologist.
Yep.
So instead of looking for look for one that's associated with one of the big academic centers, Johns Hopkins, University of Alabama. There's lots of them. And that may be a better route to go because they do clinical trials and they do a lot of research. I don't know that they're what specifically any of them are working on right now, but you know what I mean.
For folks that are looking for clinical trials, you can go to clinicaltrials.arthritis.org and check that out. We always recommend folks try that out, but working with an academic center is great advice. What is your opinion of regenerative medicine, like stem cell, PRP, in helping with arthritis?
I think the jury's still out. It doesn't seem to have gotten very far in osteoarthritis, the stem cell replacements. And I don't know how it's going to work out for any of the inflammatory arthritis. I just think it's too early to know. But I don't think we've seen anything earth-shattering yet.
Helpful advice. Next, what kind of test or lab test would you recommend someone gets if they have swelling of their knees? So we're talking about diagnosis.
Well, I would think that their primary care doctor, at the very least, if they're not diagnosed with anything, I think going to the primary care doctor and at least getting knee x-rays to see what's happening is the very least. That would be probably the starting point to have their primary care doctor do a knee exam and maybe get knee x-rays. A lot can be seen in an x-ray, before going on to other kinds of tests.
Do you know if insurance covers aquatic exercises for people with arthritis?
Some insurances do. I've written letters for patients to their insurance companies that says how much we think that the patient can benefit from aquatic therapy, listing the diagnosis and that kind of thing.
All right. 2 more questions. First is a quick one. What form of inflammatory arthritis do you see most with patients?
Rheumatoid arthritis.
Yeah. And here is our last question. This person is on methotrexate. When I'm getting a flare, I use 600 milligrams of ibuprofen twice a day. If that doesn't stop the flare, I switch to prednisone daily for a week. It seemed like this has become my norm every month. Any suggestions?
Yeah. I think I covered this. If that's happening, that is whatever your background, the methotrexate probably needs to be added on to. Either the dose needs to go up or you need another therapy with that. So, I mean, you have to discuss that with your rheumatologist. But a flare a month is not good, and that much prednisone is not good.
All right. Well, thank you so much for joining us and sharing your wealth of knowledge with us tonight. I know that the audience has really benefited from this conversation, and we are so grateful for all the things that you have done to help patients with arthritis in the Arthritis Foundation. I personally have learned a lot, and I look forward to sharing this with others. So thank you so much.
Thank you, Nick. And everyone have a good night.
Excellent. We're going to share a couple of tools and resources. First, I want to talk about upcoming webinars. If you enjoyed this webinar, we ask you to check out or share this information with a friend. We have a webinar coming up, Reframing Osteoarthritis, on December 5th. And we have a weight management webinar on January 23rd. We typically have our webinars on the fourth Thursday of every month, and we'd love for you to check them out at arthritis.org/webinars. We have connect groups. These are support groups for people with arthritis just like you. We have a chronic pain group that meets on December 9th, and they meet weekly. And we have a newly diagnosed group that's having a holiday special on December 12th. And they meet monthly, but we have more than 50 in-person and online groups. We have groups for all types of arthritis, all types of people, and they meet all types of places in person and online. We want you to find the Connect group that best suits you at connectgroups.arthritis.org. We have many, many additional resources at the Arthritis Foundation. You can learn more about your disease, how to stay fit and healthy. You can go to arthritis.org/health and wellness. We've got free ebooks to check out. These are PDFs that you can download or read on your smartphone or your tablet on all sorts of different types of arthritis and management. Take arthritis information on the go, in the car, or while you're walking with our podcasts. We've got episodes and episodes and episodes on all different types of arthritis, and every episode of our podcast is moderated by someone with arthritis. And lastly, we have our Yes tool. If you're looking for movements, physical activity, exercise that's safe for people with arthritis, check out the Yes tool. It was designed by physical therapists to give you short little videos to teach you how to exercise safely. And thank you so much for being here. But please, please tell us how this webinar went and what other topics you are interested in. You will receive an email with that link to the survey, and we beg you, please, please fill it out and let us know how we did. And don't forget that you will be emailed that recording of this webinar, and you can check out it or many other great video resources at arthritis.org/webinars. We want to give a special thank you to our sponsors, AbbVie, Boehringer Ingelheim, Bristol Myers Squibb, and Optiv Health. Thank you for helping make presentations like this possible.